But health sector is made by people we educate. They mystify education and educate people to be at service of the communities. Then we'll be ready for the next catastrophe.
Thank you very much. I would like now to invite the Honorable Issa Marto Jopair to give his opening remarks. Thank you.
Merci, la Présidente, modératrice. Moi, je voudrais remercier les organisateurs de cette importante rencontre parce qu'elle nous permet aujourd'hui d'échanger sur une question aussi cruciale que celle de la santé dans nos pays et aussi de voir comment nous pouvons honorer nos engagements parce que nous sommes tous inscrits dans l'agenda 2030 et la question de la santé occupe une place de choix. Donc au niveau du Tchad, nonobstant les efforts du gouvernement, la question d'un système de santé performant subsiste. Subsiste parce que le Tchad, bien qu'est un pays fragile, appartient à une zone sahélienne qui a beaucoup de problèmes avec le terrorisme, mais aussi au bassin du lac Tchad avec Boko Haram et autres, et qui fait que tous ces efforts-là sont souvent annihilés. Donc je suis heureux de constater qu'au niveau du Rwanda, il y a des efforts importants qui se font. À cela s'ajoute la question des changements climatiques, les questions de malnutrition des enfants, des 0 à 60 mois, mais aussi des femmes qui allaitent, des femmes en grossesse. Ce sont des questions importantes que nous, en tant que parlementaires, nous suivons sur le terrain et j'aimerais vous partager cette expérience-là. Et quand on voit les questions de malnutrition au Tchad, on voit qu'à peu près un quart de cette population-là a un taux en dessous au-dessus de 14%, je crois, que l'OMS a retenu comme seuil. Et là, je crois qu'au niveau du Tchad, c'est une situation qui est extrêmement grave. Et ceci, c'est par endroit. Par endroit. Donc, on prend, pour celui qui connaît le Tchad, c'est dans une zone saharienne. La zone sahélienne, c'est dans des zones assez précises qu'on rencontre cette situation-là avec beaucoup plus d'acuité. Maintenant, en tant que parlementaire, mais aussi la position politique du gouvernement du Tchad, conscient de la situation, le président de la République du Tchad lui-même préside une réunion mensuelle avec tous les acteurs impliqués dans le secteur de la santé et c'est mensuellement. Discute de ces questions-là pour trouver des solutions. Ceci quand même est une volonté politique assez forte par les autorités du pays. Au niveau du Parlement, nous jouons un rôle important parce que nous influençons le vote du budget. Quand il y a un budget qui est voté au niveau de l'Assemblée nationale, nous faisons en sorte que ce secteur-là soit priorisé. Ça, c'est ce que nous faisons pour qu'au moins le secteur de la santé trouve sa place malgré le contexte sécuritaire et économique difficile. Nous faisons en sorte que, de par notre position, pour qu'un budget conséquent puisse être voté. Ça, c'est en amont. Donc, on fait aussi le plaidoyer, parce qu'au niveau national, mais aussi international, faisons pour que les programmes de santé, les projets de santé qui prennent en compte cette question-là, puissent être privilégiés au détriment des autres projets. Pas négliger les autres, mais ces programmes, ces projets qui touchent les questions de santé, les soins de santé primaire, la couverture sanitaire universelle, puissent être privilégiés. Il y a une autre question, c'est les questions d'équité, mais aussi d'égalité. Ça a été abordé par le nouveau ministre, mais aussi avec la vice-chancelière. Ça, c'est pour faire en sorte que les questions démographiquement importantes qui se trouvent dans telle ou telle province puissent être prises en compte par rapport aux questions des autres régions qui sont de moindre importance, mais aussi l'accès des populations aux soins de santé primaires. Nous veillons à ce que ces questions-là soient prises en compte, et ça, les parlementaires, de par leur proximité avec les populations, parce que nous sommes l'émanation des populations, nous sommes les représentants de ces populations-là, nous veillons en sorte qu'il y ait un accès équitable, un accès juste, équitable aux services de santé. Ça, c'est ce que nous faisons. Nous légiférons aussi. Et là, le problème qui se pose, c'est toujours le gouvernement qui propose des lois liées à ce secteur-là. Les propositions de loi, jusqu'à là, c'est trop faible au niveau du Parlement du Tchad. Nous n'arrivons pas à faire des propositions de loi dans ce secteur-là parce que, bon, il y a des limites, mais le gouvernement, à chaque fois qu'il propose des lois qui prennent en compte ce secteur-là, nous faisons en sorte que ces projets de loi-là puissent être adoptés. Et ça aussi, c'est le rôle du réseau des parlementaires tchadiens sur les questions de population et de développement, mais aussi de la Commission sur les objectifs du développement durable. Maintenant, en aval, c'est le contrôle. C'est vrai, nous nous battons pour qu'il y ait des financements, pour qu'il y ait des budgets conséquents, mais nous regardons aussi en aval pour que ces programmes, ces projets-là soient bien mis en œuvre. Parce que c'est à travers le contrôle que nous pouvons déceler s'il y a un problème dans tel ou tel secteur, dans telle ou telle localité. Et nous, en tant que députés, on est souvent sur le terrain, nous connaissons les problèmes de ces populations-là. Quand on parle de gratuité, par exemple, des soins, sur le terrain, souvent, c'est mal compris. Et c'est mal compris, il faut rétablir ces questions-là sur le terrain, expliquer aux populations la gratuité, prendre en compte tel aspect des choses. Ça aussi, c'est un travail que nous faisons et dans le cadre de nos visites sur le terrain. Parce qu'il s'agit aussi de remonter les informations de ces populations-là au niveau central, mais également de prendre en compte aussi des informations qui sont prises au niveau central, pour les ramener au niveau de la base, échanger aussi avec ces populations-là, leur donner des informations pour qu'ils comprennent qu'est-ce qui les attend, quels sont leurs devoirs, quels sont en tout cas aussi les avantages sur cette question-là. Nous évaluons aussi l'état épidémiologique. Ça aussi, c'est à l'actif du réseau des parlementaires tchadiens sur les questions justement de population et développement. Nous essayons de faire en sorte que ces questions-là soient évaluées et sonner l'alarme s'il le faut par rapport à l'état épidémiologique dans le pays. Voilà un peu ce que je conclurai par le dispositif d'éveil aussi qui existe et que nous regardons si vraiment ces dispositifs-là fonctionnent ou pas. Et le rôle justement des parlementaires, c'est aussi d'alerter, de tenir le gouvernement responsable sur cette question-là. Voilà un peu ce que je voulais dire. Merci, madame.
Thank you. Thank you, sir, for sharing your experience. Thank you. Mrs. Toku-Appiah, would you like to share some of your thoughts?
Thank you. A common thread that I have found across the continents when it comes to successful health service delivery interventions, particularly in hard-to-access areas or fragile contexts, has been political will and government leadership, innovative partnerships, a willingness to be creative in the financing mechanisms, and engagement with communities or the intended beneficiaries of the service. And I believe these are themes that have been echoed by my fellow panelists. What I'd like to do to illustrate this is share with you an example from the work that I did while I was in Lesotho. And it was called the Rural Initiative. At the time, the government of Lesotho needed to roll out HIV/AIDS care and treatment across the country to the most remote parts. And as many of you know, it's a very mountainous country. The terrain is particularly challenging. And you know, I feel that the partnerships that were developed in order to deliver health service there could be extrapolated to fragile contexts. So what the government did was, under their leadership and with funding from Irish Aid, the Irish government, and technical supports and assistance with coordination from the Clinton Health Access Initiative, they launched this initiative. Prior to doing that, an assessment had taken place across the country to look at the health centers, staffing, supply chain, really to help design the project that was required. And in that process, communities around those health facilities were engaged, as well as the chiefs responsible for those areas. For the human resources, they reached out to the government of Kenya and entered into an agreement with them to recruit 100 midwife nurses that could be posted to the health centers to meet that need. The Ministry of Health provided the general training on Lesotho's regulations for care delivery. But Partners in Health, which has extensive experience working in these very difficult circumstances, and they've worked in Haiti too, was invited to come and provide the ongoing training and mentoring in the health facilities. Clinton Foundation focused on the supply chain elements of it, worked with the pharmacies personnel throughout the government system. We partnered as well with DHL and Riders for Health. Because of the difficult terrain, vehicles couldn't go all the way to most of the health facilities. And so Riders for Health, who use motorbikes, were then engaged to transport samples. So there wasn't the technology for DNA PCR in the country. And they reached out to the Central Lab in South Africa to assist. But we now had to devise a very quick turnaround mechanism so that from the time they took the samples to the time of the infant's 6-week checkup, the results would be there, and if necessary, treatment could be initiated. So using the coalition for the Riders for Health of the DHL and the Central Lab in Maseru, they were able to sort out the lab system. At the same time, we also had Mission Aviation Fellowship, who were responsible for flying out staffing, supplies, and really making sure that there was continuous communication between the facilities. So over a period of time, we were able, and today, Lesotho's driven down its HIV/AIDS prevalence rates. We've also managed to really strengthen the healthcare system in the most remote parts of the country. And the government was so pleased with the results. I was deputy director at the time that the initiative started. Before 1 year was over, the then director, country director, was invited to be the Minister of Health. But what I think is key was it was a significant partnership. We used innovative financing. Some of the funding went through the government, some went through CHAI in order to enable the rapid responses that were required. And over time, we built up the government's capacity to absorb the initiative and sustain service delivery.
Thank you for sharing your success. Mr. Nkosi, would you like to share your thoughts now?
Thank you very much, Virginia. Before I start my intervention, I would like to make a statement, a powerful statement that I read somewhere. It says, if fragile and conflict-affected states can cover their defense budget without an external funding, so they should also do the same with their health sector. You will probably agree with me that the national security is one of the biggest priorities for many countries. So health also should be. Because if we can think of any outbreak such as the 2014 Ebola outbreak in the West Africa, or the current Ebola outbreak in the eastern part of the Democratic Republic of Congo, the impact was or is huge. The reason why countries need really to prioritize health sector. That is the reason VillageReach has been working with many African countries in Malawi, Mozambique, Ivory Coast, Nigeria, to solve the healthcare delivery challenges in low-resource communities. In the Democratic Republic of Congo, where I'm based, we have been building and strengthening a political will from decision makers so that we can have a sustainable health system in the context of the UHC and the PHC. When I say sustainable health system, is a system which can withstand against political, environmental, economic, financial shocks. Practically in the DRC, for example, we have been engaging the provincial parliaments to draft and pass a law in order to prioritize health issues in the provincial development plans, but most importantly, to secure immunization and health financing within the provincial budget, because we came to a conclusion that only domestic resources are sustainable. Thank you.
Thank you very much. I've learned so much, and all your interventions have really prompted multiple questions in my mind. I'll just stick to a couple before I open up to the floor. I would like to ask Dr. Binagwaho, you discussed how you invited civil society to come to the table. You also spoke about accountability and how corruption doesn't really have room to breathe in this country, which is amazing. If you were to advise civil societies and other actors that are operating other African contexts, you might actually be doing this right now because they might be in this room. So what advice would you give them in order to increase government accountability when it comes to improving the health sector?
I talked about double accountability. And this is very important for civil society. Civil society should be accountable too. I want to ring the bell that nobody made them accountable. And if in a country like, I'm going to take Haiti because I love them and I would love that their problem is solved. They have more than 8,000 NGOs. What for? So, before making government accountable, regulate yourself. And drastically. Because there are many people in the pretext of civil society that make a living on the back of misery. And this is as bad as government that doesn't take care about their people. So, double accountability, this is what I will say, because there are so many good people in civil society that are tarnished by those who are not accountable. So this is the thing. And also, use their exposure to bring ideas to the countries in need. I want to recall that this country is where it is now because 600 NGOs has been thrown out here in 1997, something like that, because they were doing nothing than feeding themselves. Not helping Rwanda to grow. So this is also something we need to do, and I hope if there is a report and conclusion, this is back in to help that. But the other portion is bring novelties to countries. If I want to talk to Lesotho, for example, you have problem, use drone. They have, you understand? It will be so cost effective in your country. And delivery of good vaccine sample results will be like that. So there are so many things we can do, and civil society should really use their capacity to bring innovation to help countries solving their problem, reinforcing the public sector, but be themselves accountable. Create systems.
Thank you. Mr. Nkosi, you mentioned the Ebola crisis, and I'd like to learn a bit more about the challenge it poses based on your experience in the DRC. but also what strategies have been deployed on the ground to tackle this outbreak, which of course, as you mentioned, is not only an issue for the DRC, it has affected other countries in West Africa, so I'm sure your experience would benefit others as well.
Yeah, we had 2 episodes of Ebola outbreak in the space of 2 years. The first episode was last year, between May and August, in the northwest part of the DRC in Equatorial Province. But because of the political stability of the province, but also, most importantly, because of community involvement in sensitization, we were able, as a country, with the support from international organizations, to contain the outbreak within a 3-month period. But what we are experiencing at the moment in the northeast part of the DRC, in the conflict zone, which makes the riposte very complicated, because there is recurrent attacks to the humanitarian or the riposte team, but also the civil society were not at the beginning involved fully to mobilize people, to sensitize people around the vaccine availability and all the precautions they need to take. So we ended up by witnessing the outbreak taking more time than expected. But fortunately, the government and its technical partners, they started to engage boldly the civil society, and they brought them on the table. Now that the civil society started to engage the communities, they are carrying really the burden of sensitizing the community. We have been seeing a slow in terms of the new cases, and we are hoping that the outbreak can be controlled in the weeks to come. So just to conclude, that community involvement and sensitization during the crisis was and is still very important.
One thing that we haven't yet touched upon, but is very much linked to the health discussion, has to do with access to food and the whole issue of nutrition. And I was wondering whether Ms. Toku-Appiah, you would share with us some of your thoughts with regard to the opportunities to improve nutrition as we discuss actually strengthening the whole health systems.
Thank you. I think for this, I'd like to reflect on the work that the Foundation for Community Development is doing in Mozambique, following the cyclones Idai and Kenneth. And really, it's about taking the opportunity to do extensive nutrition education, which is one of the key elements of long-term nutrition improvements in a community and in a population. You essentially have a captive audience post-conflict when people are moved into camps. And it's not just about providing food to fill their tummies, but really about backing up the education you're providing with the kind of food that you provide them in these settings, and setting them up long-term for the kind of food that they need to be producing and procuring when they're able to resume their regular lives. Thanks.
Thank you very much. Well, I have more, but we'll also be keen on hearing the views and comments from the audience. So if you'd like to ask a question, you see there are standing mics across the room. So if you'd like to ask a question, please queue behind them and wait for me to call on you. When I do so, if you could tell us your name and affiliation, and perhaps also indicate which one of the panelists you're trying to address. I can see already 3 gentlemen over there. So. The first one.
Hi, my name is Emmanuel from Ghana. I would like to really congratulate the organizers for making health an important part of the dialogue. because most of the times you attend some of these events and it's all about trade and investment and security, but then health is left in the back seat. So I'm very, very proud that health has become a major topic for discussion. My question is to the gentleman, Mr. Nzoki, the one who gave the quote on the fact that if African governments can spend on military, can have budget on military, why that they are not having so much spending on health? And I would want to, maybe not to him alone, but the panel, how we can encourage African governments to increase their budget on health, because as we all know, health is wealth and it's paramount, but yet still the budget on health is quite low. And then on nutrition too, you realize that the education of what to eat and all that, it's very low in the dialogue in Africa, and so we are having a lot of NCD, so how can we improve that as well? Thank you.
Thank you. I'll collect a few questions before I return to the panel. The second gentleman, please.
Thank you. My name is Dr. Kingsley Nalwe. I'm from Federal Minister of Health, Abuja, Nigeria. I want to ask the Honorable Minister, in the morning, when the Honorable Minister for Foreign Affairs and International Relations, there was one statement he made, and it was a take home for me to my country. He said that we don't need poverty alleviation. What we need is wealth creation. And I believe that. Okay, as an expert in public health, we are into preventive medicine. We find out that some of the partners that are in Africa are into programs, and they are interested to scale up. In fact, at times they compete with a patient. So, how do you resolve the issue, the conflict of ignorance, disease, and poverty, which is the basis of most of the diseases in Africa? Because we know that to effectively control outbreak, you have to prevent spread, or you have to prevent new cases. Once you prevent new cases, you have controlled. So is there any policy document put in place to address this conflict of ignorance? Because ignorance leads to disease. And we know that disease leads to poverty. Of course, poverty, it goes again. So how do we do this thing? Instead of voting millions of dollars, say that partners are doing to control this, people are taking HIV drugs and other things, how do we resolve this in terms of preventive medicine? Thank you.
Thank you. Thank you, sir. I'd like to take two questions from the other side of the room now.
Hello. Thank you very much to the panel. My name is Samuel, and representing Bosch. My question basically is to the panel. I would like to understand, again, borrowing the words from the foreign minister in the morning, that it's time that the Africans begin to put certain topics on the table for solutions to be made for Africa. Really, I want to understand that on the world stage, for example, with regards to the World Health Organization, what are the African interests? What are they pushing on those bigger stages? I see in my country that, and again in Africa, malaria is still the #1 killer on the continent. There are times that there will be an announcement in the health spheres that a certain drug is no longer effective in dealing with malaria disease, and a new drug is more potent. But some of these drugs are not being manufactured by African pharmaceutical companies. And we have allowed these spaces to be dominated by our counterparts in other areas. So personally, I would like to understand, anybody on the panel can answer the question, that what's the real agenda that is being pushed at a bigger stages like the World Health Summit? Thank you very much.
Thank you very much. I'll take one more, also from that side of the room.
Good afternoon. My name is Mariam Yunusa. I work with the African Development Bank. Very interesting discussions. My specific question is to Ms. Appiah and to the Honorable Minister, and it's specifically related to malnutrition for children. Dr. Appiah, of course, she gave us an example of dealing with malnutrition in conflict situations. But if we look at the figures for child malnutrition, it's obvious that Africa is not meeting the target by a long shot. The level of stunting is about 10%. 2 out of 5 children are malnourished. So my question really is, how do we develop systems that really drill down to make sure that we address the problem of child malnutrition? Thank you.
Thank you. We'd like now to return to the panel, and if you could keep your answer brief, then we'll have a chance for a second round of questions. Some, of course, are being directed to specific panelists, others are for everyone, so I'm sure everyone will have views on these topics. May I invite the Honourable Minister to go first, and then in the order that you're all sitting down, please.
Thank you, and thank you for giving us the opportunity to continue the conversation. I'll start with the first question by Emmanuel from Ghana. But one quick clarification, the panel is about fragile states, and sometimes we refer to Africa. So fragile doesn't mean necessarily Africa. That's very true, because it depends, and countries are fragile for different reasons and different contexts. So just for the record. But one thing that's extremely important, and that we didn't allude to at the beginning, was that health is not about ministries of health only. There are so many things about the determinants of health that are not related directly to the Ministry of Health. And that refers us to the first question about ignorance, disease, and poverty. Health will never be addressed if it's not a whole of government effort. Never, because it starts with education, it goes with infrastructure, it goes with water and sanitation. There are so many determinants of health. And to me, sitting where I am, I realize that working on these other aspects might probably bring more health than everything that we do in the health sector alone. So it's our responsibility as a health sector to educate and say, okay, look, if you were to avoid malnutrition, if you were to avoid chronic diarrhea, you need to have water, you need to have latrines, you need to wash your hands, and get back to the fundamental things that people need to do. So that will be my quick answer to Emmanuel, and those policies are already there. A whole of government effort, work on everything that's basic services package. To get back to the question Miriam asked, because they are very related, we also in Rwanda have a problem of chronic malnutrition, and the panel that will follow will probably elaborate more on this. One thing that we realized is that when you put malnutrition under the health ministry, then you got it wrong, because it's too late. What you do, and we had these struggles, we pushed it to the Ministry of Agriculture, and then the Ministry of Agriculture pushed it to the local government, and then at some point, our president realized, no, it's not a problem of this and this sector, it's a problem that resides in the family. So now, the malnutrition coordination is under a specific body that goes up to the family level. We call it the ECD, the Early Child Development, that's in charge of handling malnutrition. And what they do, that body coordinates all the different institutions, at local government, at the Ministry of Health, the Ministry of Agriculture, and then we think that by addressing the problem at that level, at the level of the family and the household, we think that we'll be able to address the chronic malnutrition issue. Samuel asked a question about malaria being the first killer and what's the plan. Definitely Africa in general is manufacturing drugs. I mean, there's so many countries in Africa that manufacture the drugs. They are available. But the key question is how do you address the resistance that are emerging vis-à-vis the malaria, and that we've seen in some countries like Southeast Asia. You've seen that malaria has a correlation with other challenges that we are having as a global community, the global warming. In Rwanda, we realized that within the last 20 years, there was an increase of 1.5 degrees centigrade, and we're seeing malaria emerging in areas where we didn't have malaria before. So the discussion about malaria is it's a broad one about drugs, but also about prevention, about what we can do at the community level. Everything going from addressing the issue of breeding sites, of sleeping at the mosquitoes. Now that we've provided mosquitoes to everybody, we realize that mosquitoes are biting cows. And that's something that we are trying to address within the framework of the One Health, where we will not only address malaria in human beings, but also address malaria in the transmission that it offers. So malaria discussion it's a very broad one. A lot is being done currently because in this region especially there has been an upsurge of malaria cases in the last 4 or 5 years. But here specifically in Rwanda, one solution that we find is the 3 basics: bed nets, IRS, and early treatment. We push the treatment to the community. At each and every village, the community health workers, the 4 that I described, prescribe treatment to the people. So we were able to reduce malaria mortality by half over the last 2 to 3 years. Maybe I'll stop here and let my colleagues know.
Thank you very much. Dr. Binagwaho?
So, I think that the first question on security, just be sure of one thing. If there's something linked to security, is health. And to show you the importance of that, the imported case of Ebola in US 2 or 3 years ago, were guarded by Marines. Okay? Not by police, not by the neighbors, by Marines. And if we don't manage to cooperate better among countries, because this is not an issue of one country, it's an issue here about African Union. And this brings me to the role of WHO and the role of Africa there. African, I am an advisor of WHO, but let me tell you, your voice in WHO is peanuts. Why? Because we allow it. Don't complain, don't point the fingers, and you will know why. Look how WHO Afro is designed. North Africa is not in. So we address sub-Saharan Africa. North Africa is with the Middle East. So when we have a voice in Geneva, it's divided. Let's come together. We have 2 entities. You ask a solution and system. We have 2 entities that talk for all of us. The Minister Council of African Union, that is very weak, don't do much. And the Minister of Sub-Saharan Africa who meet in Afro, that is very weak, doesn't do much. The same people, working for the same country, report to the same president. Merge it and do what Latin America is doing, PAHO. Meaning, the equivalent of African Union are the one having a voice in Geneva, back up with the policy of the country, of the continent. And we will be the voice, they will be the voice of the continent and the country. So reform Afro, merge it with the Council Ministers of African Union, and then start to think about having a voice. And the question on long-term education, lack of education, bring disease, bring poverty, etc. Educate, primary school, secondary school, and after that, community education. We have a specialist in this room. Go and ask her how to do that. She do engineers in 6 months, people who can do solar and other things. Educate, and don't wait people to be poor, because after that it's more difficult to educate them when they are poor. Educate now, starting by primary school. And for the coordination of partners, there's something I want to insist. Communities and civil society are two different things. Civil society are people who are made their business and living on helping communities to be better, in partnership with government and other partners, development partners. But our true clients are the communities. And my biggest important message is WHO, the Council of Ministers in African Union. Stand up and go and bring the message at home. The minister will bring it here.
Martha Jabir, would you like to address some of these questions?
Merci. Je dirais simplement que c'est l'exécutif qui met en œuvre les politiques, les programmes, les projets. Mais en tant que parlementaire, nous avons aussi notre rôle à jouer, c'est ce que j'avais dit précédemment. Vous savez, les questions, je trouve qu'elles sont transversales. Parce que la santé, c'est le fondement du capital humain. Mais c'est aussi une valeur ajoutée à l'éducation. Quand on prend tout ça, je crois qu'on ne peut rien faire sans la santé. Et quand je prends un exemple comme celui de mon pays, le Tchad, où nous accueillons des réfugiés, nous accueillons des personnes déplacées qui passent d'une région à l'autre, c'est un fardeau énorme. Et la problématique n'est pas la même quand on prend un autre pays qui ne vit pas la situation. Et ceci est extrêmement important parce qu'il faut une approche différente. Nous avons des réfugiés à l'ouest, aux confins vers le nord-est du Nigeria. Nous avons aussi une situation sécuritaire difficile, la frontière avec la Libye. Nous avons le Soudan, nous avons la Centrafrique, où il y a des déplacés, il y a des réfugiés dans ces régions-là. Et les problèmes de malnutrition se posent avec acuité dans ces zones où on a des déplacés, on a des réfugiés. Donc ce qui pose aussi une autre approche, et je crois que c'est le rôle des parlementaires de pousser l'exécutif dans ce sens. Quand vous prenez la sécurité et la santé, moi je crois que les problèmes sont liés. C'est une question souvent de développement. On ne peut pas laisser d'un côté un secteur et privilégier l'autre. Je crois qu'en tant que parlementaire, nous faisons en sorte que ces questions-là puissent être prises en compte dans le cadre global et que les solutions soient trouvées dans ce cadre-là. C'est ce que nous, en tant que parlementaires, nous voyons, mais l'exécutif qui a la charge de mettre en œuvre les programmes, les projets, les politiques, a aussi ses priorités, mais nous allons nous entraider parce que les lois, c'est l'Assemblée qui les prend, et quand nous voyons que c'est quelque chose qui va dans ce sens, nous le ferons, et je crois que c'est comme ça que nous pourrions avancer, mais le problème est là, et je crois que en tant que parlementaire du Tchad, ce que je voudrais dire à la fin, c'est que nous ne pouvons pas nous soustraire de cette dynamique-là. On est obligé d'aller dans ce sens. Tout peut attendre, sauf la santé. C'est ce que je voudrais dire pour le moment. Merci beaucoup.
Thank you very much. Mr. Nkosi, would you like to give your responses?
Yeah. So there is a need for a robust advocacy, not only from civil society organizations, but also all other actors. We need to make our message heard to the government. If they don't listen, we need to cry until they will get the message. And we are lucky in the DRC to have a network of parliamentarians involved in immunizations. Before 2009, there was no immunization expenditures or budget within the national budget. But that network of parliamentarians, they stood up. They used all the illustrations you can imagine, making a comparison between the security threats, national security threats, and health threats, and talking to their peers, talking to the government. For example, to the peers, they say, as parliamentarians, we always stand up to address the assembly. But if you are affected or you are affected by polio, you won't be able to stand up. And they used all the illustrations. And for example, to the government, they said, even to catch a big fish, you need to put a bait. Although they are international partners, they are coming, but we need that bait to catch a big fish. Eventually, post 2009, the government started to include immunization budget within the national budget. Then the second part was the disbursement rates. Even though the budget is there, but the government doesn't disburse. They continue advocating the government. And today, I will say, for example, we do purchase vaccines with our own resources. It's one battle won, but we still have more battle to be won. So it is possible really to push the government. At the end, as I said intentionally, only domestic resources are sustainable, because when you look at all the transitions, polio transition, Gavi transition, and so on transitions, they are not a lot of organizations that are willing to support any country forever. So countries need to take their responsibility. We don't, for example, as civil society organizations in the DRC, we don't take any excuse from the government for not to spend on health. And we want them to make it as a priority. Thank you.
Thanks. Well, Ms. Toku-Appiah, you have the last word.
Thank you. I believe that my fellow panelists have answered quite comprehensively the questions around malnutrition. But I just want to emphasize the multi-sectoral and multi-stakeholder efforts that are required to address malnutrition. It just can't be the health sector alone or agriculture. The entire system required basically to produce and move nutritious food from the farms to the plates where it's going to be consumed. All the actors involved in making that happen need to be involved. My colleague, Mr. Nkosi, said, we need to shout till our voices are heard. In the nutrition space, the analogy is we need to make nutrition visible. It's largely invisible, unlike the roads and the schools and other infrastructure that leaders can get behind very easily. It's different with nutrition. And so we need to find ways to communicate that enable people to understand. In many of our languages, there isn't even a word for nutrition. More and more, we are starting to make inroads with finance ministers because we're now speaking about nutrition in terms of economic impact. So we need to find ways to communicate such that all the different stakeholders understand their particular role in delivering good nutrition. Thank you.
Thank you very much. I'm afraid we have run out of time. I think we will all agree this has been a very enriching and stimulating discussion, and thank you in particular for sharing your concrete expertise and experience. And apologies to those in the audience who wish to ask questions. Unfortunately, we did not have time to do that. Before we move on to the next section of the conference, please join me in thanking our panelists.